Hi, everyone. My name is Robin Feinberg. I am the Senior Program Manager of Clinical Affairs at the College of Nursing. On behalf of the college, I would like to welcome you this evening. We know how busy you are, and we're so glad that you have chosen to spend the next hour and a half with us for a workshop on scope of practice led by Dr. Carolyn Montoya. I know most of you know her and she doesn't really need an introduction, but I'm going to go ahead and offer a brief introduction. Dr. Montoya is professor and interim dean at the UNM College of Nursing. She received her bachelor's degree from the College of Nursing at the University of New Mexico, her master's degree from Yale University, and her PhD from the University of New Mexico as a fellow of the Robert Wood Johnson Foundation Nursing and Health Policy Collaborative. Dr. Montoya has had a progressive career of teaching at the undergraduate and graduate levels at the College of Nursing and has served as chair of the practice team and coordinator of the family and pediatric nurse practitioner concentrations. Prior to her administrative appointments, Dr. Montoya maintained a clinical practice as a certified pediatric nurse practitioner. Dr. Montoya is a past president of the New Mexico Nurse Practitioner Council, the American College of Nurse Practitioners, which is now a part of the American Association of Nurse Practitioners, and a past president of the National Association of Pediatric Nurse Practitioners. She is a fellow of the American Academy of Nursing and the American Association of Nurse Practitioners. The New Mexico Center for Nursing Excellence selected her as the 2020 Distinguished Nurse of the Year. Welcome, Dr. Montoya, and thank you for sharing your expertise with us this evening.
Thank you, Robin, for that lovely introduction. So we are going to be talking about scope of practice and keeping patients safe and making sure that your license remains intact. So the first thing that I'm going to do is have a land acknowledgement. We do this on a regular basis because, as you know, we want to pay homage to the indigenous people of our state. So founded in 1889, the University of New Mexico sits on the traditional homelands of the Pueblo of Sandia. The original peoples of New Mexico, Pueblo, Navajo, and Apache, since time immemorial, have deep connections to the land and have made significant contributions to the broader community statewide. We honor the land itself and those who remain stewards of this land throughout the generations, and also acknowledge our committed relationship to Indigenous peoples. We gratefully recognize our history. Okay, the objectives are really to look about the definitions that impact scope of practice for NPs, and I'm going to really focus on our Board of Nursing scope of practice as it applies to practice. And then we're going to have, I'm going to introduce you to a method about how you could evaluate when someone asks you to do a new procedure or treatment to an NP practice. I do not have any conflicts of interest, and the really big thing I want to say is I am not a lawyer. So I'm not giving you legal advice. This presentation should not be construed as legal. I am not a lawyer, and hopefully I hope none of you need a lawyer. All right. There's lots of, as you know, as nurses, there's a bazillion acronyms. This PowerPoint will be available to you after the presentation, and I'm not going to go through these, but this is, just, we are quite the alphabet soup in nursing with our abbreviations, and sometimes it can get a little confusing. So, scope of practice, it's a set of rules, regulations, and boundaries within which a fully qualified NP can practice. So scope of practice is really there. It's necessary for public protection, and that's what the Board of Nursing does. It's the legal term used by states, and it defines what activities and what an individual professional can do. So remember that while scope of practice is regulated by the state, so every state has a different scope of practice, NP programs, nurse practitioner programs, really adhere to a set of uniform educational standards and require national certification exams so that is for entry-level practice competency. So even though those states have the scope of practice, we really work hard to have this uniform standards for nurse practitioners, and of course the certification exams that go with that. So this is a model from 2008, and I always go back to this. Some of you may remember this, some of you may not have heard about this. So there for a while, with the nurse practitioner movement, there were lots of NP programs popping up across the country. So you could become, believe it or not, these are things that I heard. You could become an airport nurse practitioner if you wanted. So there were these strange things coming up. So what happened is the nursing community came together and they developed what's called the consensus model for advanced practice RN regulation. And it's called LACE because it comes up with licensure, accreditation, certification, and education. What this slide shows you is that basically we have 4 NPR roles. We have nurse anesthetist, nurse midwife, clinical nurse specialist, and NP. And then it sort of goes to the population. The circle at the very top here is talking about specialties. This is not saying that you cannot become a specialist in, maybe you're a specialist in oncology, maybe you're a specialist in emergency room care. You can get a certificate of that. But what your title is, you could put that at the end of your title. Your title is these 4. These are your titles. And then for me, I'm a nurse practitioner, but I'm a pediatric nurse. Whoops, let me go back. I'm a pediatric nurse practitioner. So that's what comes for me. Or in peds, again, they could be neonatal, adult gero, or psych mental health. This is what we have to concentrate on. So scope of practice for primary or acute care, it's not setting specific. I get a lot of questions about, I'm a family nurse practitioner, can I work in a hospital? It's not about the place that you work, it's what the education that you have and any special certifications that you have completed. So that's the first thing. That's what we have to be clear to the people that we work with and to our patients. It's always important to identify who you are and what you do. So in terms of licensure, full practice authority, we are in a full practice authority state where we are allowed to do the evaluation and diagnosis of patients. We get to order tests and do treatments. So there are 24 states. I updated this at the end of 2022. This is from the American Association of Nurse Practitioners, that we have 24 states plus Washington, D.C. that have full practice authority. We also have prescriptive authority. We do a little bit better there. We have 46 states that allow prescription of Schedule II controlled substances, including Washington, D.C. You can look at a map. If you belong to the American Association of Nurse Practitioners, they have lots of information in terms of practice authority. So if you look at this, you can see where there's the full, I'll go from the bottom up actually. Here are the full practice authority states, all of these in gray. And you can see that they tend to be a little bit in the Midwest of the country, but they also swing to the West. So, except for this outlier. Anybody have an idea why? You can put in the chat why you think this California is an outlier. California is an outlier because it's controlled by medicine, and medicine does not want full. There's so many physicians here. They have worked for years and years and years to get full scope authority. So we have 10 states that are a little bit limited, and then this state where there's just no ratios, these are really restricted. So the blue are the most restricted scope of practice in the country. So for the students that are on this webinar, you're very lucky to be in New Mexico because we are full scope. And we have been, if you saw the announcement from if you belong to the New Mexico Nurse Practitioner Council, we are celebrating this year 30 years of full scope practice. And so that's really quite remarkable. Yeah, that is a big clap all around. Okay, we do better with controlled substance prescriptive authority, 46 states plus Washington, D.C. We have a few outliers here. These yellow states, they're limited to only hydrocodone combination products in Missouri, Arkansas. And then in here, there's just no prescriptive authority. So, but overall, we do very well there. Okay, so that's just scope of practice across the country and what it looks like. What do we have to do in terms of our education system? Well, you have to have a graduate degree or a postgraduate certificate. And I'm including this because it is so important. And when we're talking to individuals who are interested in becoming a nurse practitioner, the very first thing, or even when you're becoming an RN, is you need to be sure that the institution you are attending is accredited. So the College of Nursing at UNM, since it first started its first nursing program way back, has consistently been accredited. We get accredited every 10 years. We happen to use the Commission on Collegiate Nursing Education, which is associated with the American Association Colleges of Nursing. There is another commission for nursing education called CNEA, and that's associated with the National League for Nursing. They're both very good. It doesn't matter which one you have, as long as that institution has certification. The American Association of Colleges of Nursing, which we belong to, has core competencies for nursing education. These, they have just, in 2021, they revised the essentials model, and they basically have two levels. Level one is entry level, and that is talking about your initial nursing degree that you may get. And level two is the advanced nursing education, and that would be for the APRNs. So this is something that we have to abide by, and here at the college, we are in the process of moving towards having all of these essentials in our curriculum. And I just cannot tell you how much I appreciate the faculty, and I know that Dr. Schimmels is in on this call, and what they have done to get us moving in the right direction to meet these essentials. So here's what they look like. They have 10 domains of nursing, and then they also have concepts for nursing practice. And basically what they really want is that we are teaching these 4 spheres of care, that we are teaching about wellness, disease prevention, chronic disease management, hospice, palliative care, and regenerative restorative care. So this is a lot that we have to integrate. And as I said, we are in process of moving all of our curriculum from undergraduate through graduate into this model. So accreditation, I told you that, we have to be accredited by CCNE. Part of that accreditation involves this book that's the standards for quality nurse practitioner education. This is the latest one we have by 2022. It is a national task force that has been formed for a very long time for quality nurse practitioner education. And the accrediting bodies require that not only do we have to meet their requirements, we have to meet these standards as well. And this one is really important. So it's known as the National Task Force, NTFS, and it has 4 sections with it that we have to go by. So basically, the standard 1 is talking about the institution, the philosophy. Then you have to have sufficient resources, the correct number of faculty, the faculty that have that expertise, and of course the curriculum has to be one that prepares students for the NP role. And then the fourth part is really how we evaluate what's going on through our assessment of the outcomes and curriculum. So these are absolute and have to be met. I want to highlight a couple of things in here that got changed. The last time I think this was changed was probably over 10 years ago. A couple of things that you see at the top is that we really need to have a commitment to the community we serve. And in New Mexico, that community includes our rural and underserved populations. There is more of a focus on diversity, equity, and inclusion, that we have diverse faculty and as well as staff and in our hiring process. The other thing is that whoever is running the program, oversight of whatever track it is, whether it's AGA, CNP, or FNP or PNP, they have to be doctorally prepared and they have to be certified in that NP population. When Robin was doing my introduction, she said, I previously was the director for the FNP program and then I started the PNP program. I'm a PNP. At that time, when I was the FNP director, it was a little loosey-goosey. But as we came to another accreditation cycle, man, they had to cut me right away because it is very clear that they want somebody with that. I mean, I had worked with FNPs a lot. I'd done lots of site visits, but for accreditation, it's got to be the same. The person leading that program has to have that, has to have the same credentials. Also, teaching, 1 full-time NP program faculty for 24 students, all faculty who may or may not be NPs who teach, because we have other courses that may not be an NP. We can't exceed this ration of 1 to 8 in terms of our faculty. And you have to have interprofessional. I've highlighted this one, about 750 direct patient care clinical hours, and that does not include simulation. What you may or may not know, prior to 2022, the standard was 500 hours. Every program had to have 500 clinical hours. We at the College of Nursing have always been above 500. We don't have a single program that was that low. In fact, in the early days, we were over 1,000. Our nurse midwifery program continues to be at 1,000. The remainder of our NP programs vary between 850, 900 at some points. So we've always been above that, and that was because we had full scope practice and we were sending students, graduates, out into communities that were rural and underserved. So we really felt very strongly that they needed more clinical hours. So I know that many of you are preceptors, and I cannot thank you enough for how you precept for us. We would not be able to do this without you. What is happening though is there are lots of schools that take lots of students. They're going to have to go from their 500 to their 750. So what we are facing now, we had a difficulty placing students prior, and now it's going to be even worse for other programs that come in, and now it's 750, and that will not include clinical hours. We also have to have an immersive experience. No problem for us. We have always had an immersive experience for our students in their last term. So we manage these very well. The other standards I told you were from the National League of Nursing. I just wanted you to be aware that they are similar in terms of excellence, accountability, about what they do with faculty, students, and curriculum. We, as I said, are really under CC&E. Accreditation. There's lots of, we have to be accredited, but there are additional organizations because we're nursing and we like to make things more complicated. It's not just enough to be accredited by CC&E. If you're a midwifery, you have to have accreditation from the Commission for Midwifery Education, and they come here and do a site visit, and we have our midwifery program. The American Association of Critical Care Nurses, you could do that. It's not a requirement. The National Association of Pediatric Nurse Practitioners have some standards that we would certainly meet. And then the National Organization of Nurse Practitioner Faculties, or NOF, they talk about acute care and primary care nurse practitioner practice. So this becomes a very involved process to ensure that you are providing the education that's necessary and that you're accredited. The other thing is about certification. Certification is required, and we have different boards. So midwifery has the American Midwifery Certification Board. Most people get American Nurses Credentialing Center is where they do their certification. And I've listed the ones that they certify. They used to do pediatrics and they stopped. So pediatrics I have down on here is really now all through the Pediatric Nursing Certification Board. They no longer do pediatrics from ANCC. The other option is the American Academy of Nurse Practitioner Certification Board. They do FNP, Adult Gero NP, and Emergency. The Association of Critical Care does Adult Gero Acute NP, and then PEDS does all of those. And there's we still have Women's Health NPs, and there's a National Certification Corporation. So you have to be certified, and there are some options with this. And some people like one test, some people, but really they're all very well done, but it is a must. So people have to be certified. So what about the DNP? So in 2004, the initial position statement on the practice of the practice doctorate in nursing came out, and that was going to be the graduate degree for advanced nursing practice. The National Organization of Nurse Practitioner Faculties in 2018 came to a position statement on the DNP that was going to be the entry to nurse practitioner by 2025. Now, so many schools are moving in that direction. We are currently in process in moving in that direction. NOF has listed this statement, but NOF is a professional organization. It is not a certifying body. At this point, our certifying bodies are also in line with this, but they are not at this time requiring it. So you have to be a little bit careful here. It's going to move to this, and NOF recommends this as the organization, but they are not an accrediting body. And our accrediting bodies are on task with this. They do want this to be the entry into practice. They are simply haven't said they agree with the 2025, but they haven't said you absolutely must. So that's a bit, of a disconnect there. Okay. In 2022, they released a nursing practice education conclusions. They looked at DNP programs to see where they were, and I've just highlighted a couple of things. A few things that the DNP programs and students enrolled continues to increase. More programs are going to be DNP. It does add value, and that's the evidence-based practice, the organizational change, QI projects, quality improvement and leadership. It does not, it does focus as well on increasing racial, ethnic, and gender diversity. There is not a lot of data about the skills and value of DNP. So these are things that the American Association of Colleges of Nursing continues to look at to see how things are going with the DNP. Okay, so that's at the national level. Let's talk about Board of Nursing rules. So you have to have a current RN license from New Mexico or multi-state RN license. You have to have a completion of a graduate level nursing program that prepares NPs. So the initial license after January 1, 2001, the program has to be at a master's level. So I don't know how many of you are my age when you remember that actually nurse practitioners started off as a certificate program, and then it moved to a master's program. At one point, what happened was Centers for Medicaid, Medicare Services, CMS, they made a ruling that you could not get reimbursed unless you had a master's degree. And that's really how the master's degree came to be the degree you had to have and not certification. Education, you have to document the date and type of certification, and you have to have national certification. There are still some states that don't. I didn't check. The last I knew is that California did not require it through the Board of Nursing. However, certification is required a lot in terms of billing. And so really everybody has to get certified. So we have, this is our statute, and the statute is open right now in the legislature. It opens, I want to say every 11 years, but I don't quote me on that. I'm not positive. We practice independently. We serve as primary, acute, chronic, long-term, and end-of-life healthcare provider, and we collaborate as necessary. As of December 2, 1985, national certification was required. So there's the standards of nursing practice. So I always like to make this very clear. As a nurse practitioner, you have in New Mexico, you have this great scope of practice that you can do. But you also have to remember that you're still a registered nurse. And because you're a registered nurse, you have to practice nursing safely and in accordance with your licensure and to perform specific functions or procedures in that area. You have to have the knowledge. This is very key. This slide is really key in terms of when you are thinking about, can I do X, Y, or Z, that we're going to talk about here in a little bit. You first are an RN, and then you are an advanced practice, and you have to meet both standards. So the nurse practitioner, you can do the nurse practitioner rules. This is rules now, is that you're responsible if you're going to do something that it's not clear, you're responsible for obtaining the appropriate knowledge, skills, and supervision. You need to, for whatever you're doing, it has to be safe and competent. And this is really clear here. Respond to any complications that may arise. This is really a key part in terms of how you determine when somebody's asking you to do a procedure. And I'm going to go into more detail about that. But this is a rule. If you're going to do something that your educational preparation did not prepare you for, you have to get that education. You have to be prepared to do it, and you have to be prepared for whatever the consequences are. So keep that in mind. All right, so here's the importance of accreditation and Board of Nursing regulations. I think you all heard this. There's a fraudulent nursing diploma scheme leads to federal charges against 25 defendants. This was in Florida. So we had more than 24 individuals. They were had a scheme where they created illegal licensing and employment shortcut for aspiring nurses. Additionally, they were giving bogus diplomas, and so that unqualified people were obtaining licenses and jobs in various states. And the overall scheme here in 3 South Florida-based schools, more than 7,600 fake nursing diplomas. Now, this is the first that we heard, and this was back in January. And since that time, there have been several other states where this has been occurring. I want to assure you that the Board of Nursing here looked very closely into this. We have not had this in our state, but there are several states that have had this happen, and that is not safe. Okay, so let's get to the meat of this. So, and I've given you sort of the background. How do you make a decision for expanding your scope of practice? Well, there's what I call the old model. The old model was see one, you just had to see somebody do it. You would do it once, do one, and then you would teach it. Or maybe you would see one, and then you would do a lot of them, and then you would teach a lot of other people how to do it. Or back to see one, do one, teach one. Would you be doing it on simulation? And when would you really do a real one? This is the time, this is the era of, oh, I'm going to teach you. So let's say that you're working with a physician. I'm going to teach you how to do this. And after I do that, you can be doing it. This does not work now. This does not work at all. So if you are trying to do some expansions, you as a credentialed NP, to determine your scope of practice, you really need to know what your institution is saying. Your institution can't expand your scope of practice, but they can actually restrict it. They can't expand, but they can restrict. You have to really know your Board of Nursing regulate practice. Back in 28, I was taught when Dr. Sasha Poole was the executive director, Sheena Ferguson is the director now. She said she would get about 15 to 20% of her phone calls related to scope of practice. The New Mexico Board of Nursing cannot authorize a nurse practitioner to expand scope of practice. They can't, if you call them and you ask them, can I do X, Y, and Z? They can't tell you that. Now, what they can do is they can talk to the Advanced Practice Advisory Committee, and I'm on that committee this go around. That committee advises the Board of Nursing and reviews issues related to advanced practice. It typically is composed of, we try to get NPs from each of the areas, you know, acute care, nurse anesthetist, clinical nurse specialist, geriatrics, so forth, so that we have good variety of different NPs to discuss when these things come up for the Board of Nursing. And so we advise them. It's a very good board. I would highly recommend if you want to, when you see an opening or you can apply, it's a great committee to work with. So there's lots of decision-making models in the literature. Some talk about legality, about whether that's within your scope. Is it prohibited by law? Some deal more with competency. Are you competent to do something? Or is it safe, and what's your accountable? So these are different kinds, but I'm going to show you, and Mike is, Mr. Kisner is going to drop this model that I'm going to show you here, because this is the best thing I've found since buttered bread. This is scope of practicing nursing, a scope of nursing practice decision-making framework. This was developed by the Tri-Council for Nursing in 2016, and they involved all of these organizations. This is an article by Ballard et al. I have references at the end of this, but let's go through this. So scope of practice, if somebody asks you to do something, Is the activity, intervention, or role prohibited by the Nurse Practice Act? And when I say Nurse Practice Act, I'm not just talking about your NP, I'm also talking about your RN. Is it in conflict with this? If it's not, if it is, then you have to say, no, I can't do this. This is not within my scope. If it's not, then you go to the next step. Is performing the activity, intervention, or role consistent with evidence-based nursing and healthcare? If you're being asked to do something, is there evidence that what you're being asked to do is evidence-based? Is there literature that supports evidence-based? If not, don't do it. If yes, there is, are there practice setting policies and procedures in place to support you of performing this activity? In most large institutions, there is going to be something like that. In smaller, let's talk about a very small clinic, there may not be. And so you have to consider that. There should be something about a policy on how this is done. Have, as the nurse, completed the necessary education to safely perform the activity, intervention, or role? So I spoke to this before. It's not enough for a physician to say, look, I'm going to teach you how to, I'm trying to think, I'm going to teach you how to remove a toenail. Maybe you've never done that procedure. You're going to need some backup there, that you have more than one person just showing you how to do something. That's not going to be sufficient if something goes wrong. Is there documented evidence of the nurse's current competence to safely perform the activity, intervention, or role? Have you gone to a workshop on this? You should definitely keep that if you're going to do some kind of special procedure. I went to XYX, presentation, or I engaged in a simulation to learn this. Does the nurse have the appropriate resources to perform the activity? Is everything that you need at that clinic to do this new activity that you may want to do? And the next to the last, think about this. Would a reasonable and prudent nurse perform the activity, intervention, or role in this setting? So what does that really mean? Well, let me tell you, I used to do some malpractice. I used to read, and some of you may have done this, where you get asked to be a consultant on a malpractice case. And normally, it was obviously, since I was pediatrics, that's what I was working with. And so I was considered, this expert or this consult on this. And most of the time they looked okay, but I had one particular case where what was being done was not appropriate for that person. So you have to think down the line, is this what the average NP or nurse midwife or clinical nurse specialist would do? Is that reasonable for the setting? And last but not least, if you are doing a procedure, do you have the preparation to handle a procedure that does not go well? Do you have the equipment necessary in that office? Do you have the knowledge as what to do if that does not work? So that is something. This is a really nice way to think about how you're doing this. Be very careful of somebody who asks you to do something and they're going to tell you, I'm going to teach you. That's fine. But if you really want to do that, then you should work out a plan of how you're going to learn this and have that on file. Have that as a file that I did this kind of learning. I, read these articles support what we're doing, and this is how we practice this. It has to be written out. It will help you should something go wrong. And remember that last one, that you have to have this intervention. Okay, so I've done all the talking, And since I've done all the talking, I'm going to stop. And now what we have is we have case studies. And what we're going to do is we're going to put you into groups. So I am just going to read these through for you. And what's they're going to be, I think, Julia, you're going to put them in the chat, the cases, right? Okay. And then we'll put you in rooms so that you will have that in the chat so you'll know what case you're going to be doing. So you're going to use the this scope of practice, and Julia will put that in the chat as well. And then I'm going to ask you to provide a resolution with your rationale to the scenario. Now, the first thing I want to tell people is don't, we're not going to leave you in there for a long time. Is just if somebody would just decide that they're going to be the person that reports back. So don't take a lot of time, step up and decide that you're going to be the person that's going to provide this, what you think needs to be done. I'm just going to read them through. There's 8 of them. I have 7 on one slide, and then the 8th one is a little bit. All of these, I asked, at one point I asked individuals, NPs, to give me some examples of what they had been asked to do. So the first one is an adult Gero NP. She applies for an NP job in the ICU where she's been working for 10 years as an RN, stating that her RN skills as an ICU nurse and her education as an adult Gero NP provide her with the expertise to function. 2 is an AG ACNP hired by a practice in a rural setting, and she's been told that during the winter months, when the practice handles more sick children than usual, that he will need to provide care to ill children. 3 is an FNP hired in the fast track in emergency department to see all urgent care patients who show up, so the ED trained providers can see the truly emergent cases. All is well, except with the FNP covering less acute and the 2 ED providers covering the emergent patients, until the hospital loses 1 provider and now can only staff 1 ED provider per shift. The FNP is told they will have to cover all patients who come in if the ED provider is tied up with a severe trauma. 4 is a PNP required to take call for all patients in a clinic setting, including adults, because you're really just doing triage, and even an RN can do that. 5 is you're a member of the New Mexico Board of Nursing APRN, and a request comes to the committee from an adult Gero acute care NP who would like to be a first assist with a surgery group in Albuquerque. And the AGAP has been working with this group for 5 years and has been observing surgeries. 6 is an FNP who has been working with a cardiology practice for 10 years, seeing patients in the clinic during hospitalization for heart failure, has been managing diuretic therapy on medical unit, and is that management within the scope of practice for the FNP. An RN, 7, an RN completes her program as adult NP. She applies for an NP job in the ICU where she has been working for 10 years as an RN. I think this may have come twice, but we'll put it in. As an adult NP provider with the expertise to function as an NP in the ICU. And then the last one is sort of a long one. This is an FNP, primary care provider for medically fragile, terminally ill children who should be on hospice, but is not because the parents have declined. The infant has a lot of problems, has been to ICU. The FNP is expected to see the child because the 2 pediatricians in the practice have declined. One MD already has too many complex patients. The other MD does not agree with the parents. Desperate attempt to keep the infant alive a little longer and feels the parents' actions are cruel. Either the FNP agrees to see the infant or the family has to drive a minimum of 30 minutes to see the next closest primary care provider. We're always looking for something better. If you have suggestions for other presentations that you would like to see, please let us know. We're out there to support you, and we are so grateful for all of you. Thank you, everybody.